despite the half term, despite the Diwali and New Year festivities for some of our friends, I am absolutely thrilled to see so many on the screen this evening. And can I also add my welcome to you all? Really good to have your company this evening. So, as Judith mentioned, I'm Ketan Sheth, Chair of Northwest London Joint Health Scrutiny Committee, as well as Lead Governor for Central and Northwest London NHS Foundation Trust. So, the theme for this evening is, as Judith mentioned, end-of-life care, the importance of conversations and the need for equal access. As I say, every month, 1 hour that we have this evening is not going to be enough, but I am keen for us to start this conversation. And to help me start this conversation, I am pleased to be joined this evening by my friends, Professor B.V., the National Clinical Director for Palliative and End-of-Life Care, and Dr. Lyndsey Williams, Northwest London GP Clinical Lead for End-of-Life and Care Homes. The term end-of-life can strike, I am sure, terror in hearts and minds of us all. But sadly, it is a fact of life. We are born, we live, we die. Towards the end of life, I believe everyone should be able to live as well as possible in the place of their choosing and to receive the care they want and need. Currently, this is perhaps not always the case, and the most disadvantaged in our communities are least well served. Inequalities present throughout life increase at the end of life. We know that end-of-life care is provided for people nearing the end of their life. The care provided should aim to make sure that they are able comfortably to manage their pain and other symptoms. It also involves emotional, social, and spiritual support for the person, their families, and friends. The pandemic threw a spotlight on the end-of-life care. Many more people died at home than before, but many spent their last days in hospital or care homes without any loved ones around them. There have been numerous government strategies, including a recent approach from the NHS to transform care. Here in Northwest London, the local NHS is currently undertaking work to see how improvements can be made to community-based specialist palliative care. And I'm sure Lyndsey will tell us a little more about this in a moment. What I think helps is fairness, equal access to care, being able to make choices, honest conversations with family, friends, and professionals, all enabling the person to make the most of the time left. What hinders is lack of equality in access to the services and the quality of care and support. The rights of all of us, whoever we are, wherever we come from, whatever our beliefs. And if care is to improve, collaboration is indeed needed across health and social care and other partners. To address the challenges, a range of organizations involved in palliative and end-of-life care have agreed on 6 ambitions for 2021-2026, which include fair access to care for everyone, regardless of who they are, where they live, or their circumstances, the need to maximize comfort and well-being, and informed and timely conversations. This applies to all NHS and social care services, or rather, that people's own choices to be facilitated by services they are in. And friends, to discuss some of the work taking place, let me now welcome Dr. Lyndsey Williams. Lyndsey is a senior GP and is the Macmillan GP for Brent. She is the Northwest London lead GP for end-of-life care and care homes. Lyndsey is value-driven with a goal to upload the best clinical care for a local population. And I'm so delighted that she is with us this evening. So Lyndsey, a very big thank you for finding the time to join us. I know how incredibly busy you are. So if I can please ask you to spend perhaps a few minutes, and I said 1 hour is never going to be enough. I know 1 hour is not going to be enough for this hugely important topic, but if you could spend a few minutes providing us with an overview of the work that you are doing, please, that would be absolutely great. And we are friends going to be joining by also Professor B. Wee a little later, and I will be introducing her once our friend Lyndsey has spoken. Thank you, Lyndsey.
Thank you very much, and welcome everyone. Thank you for having me this evening. I've got a couple of slides and I'm going to talk to them and then come back to me shortly, just to give you a little flavour of quite what we have been doing in Northwest London and all the hard work that is still ongoing, but also all the opportunity for yourselves as members of the public and our residents in Northwest London, your opportunity to tell us as well and feedback to us on what matters to you in regards to end of life and specialist palliative care. So I'm going to share my screen now, and hopefully you can see my screen. Please let me know if everyone can see this, because I can't see anyone.
Not just yet, Lyndsey.
No.
Ali, have we clicked the share link?
Yeah.
You have? Okay, don't worry, bear with me.
You're
I think the
co-host,
Zoom
so you should
meeting-
be able to share. If not, I can do it.
I think the Zoom meeting wouldn't be a Zoom meeting if we didn't have a little bit of a technical hitch, but I think that makes it even more exciting, right?
It does.
So just to bear with us while we just try to sort out the slides, friends.
You would think that I've got better at this.
Would you like me to share?
I try to share them, but it's saying that I'm participant disabled.
Oh.
From sharing. It says all participants are disabled from sharing. But maybe as Lyndsey's a co-host, maybe she's enabled.
Maybe, Ali, if you could make Michelle a co-host, and then perhaps Michelle can do a double act with Lyndsey. Would that be okay, Michelle?
That's fine.
Yeah, more than happy.
Lyndsey's come back in again. I think she probably froze.
Great, thank you. Sorry, technical glitch. But what I
Michelle, can you share now?
Let me just check. Share screen. Can people see that?
Woohoo.
It's working.
This is great.
Thank you for bearing with us, friends. Thank you.
Brilliant. Can everyone hear me now?
Yeah.
Yes. Yes.
Okay, brilliant, lovely. Okay, so this is my slide deck. Thank you, Michelle. So just wanted to cover this first slide.
Michelle, are you able to blow the slides a little bit so that our friends can see it? If you could just blow it up a bit. Thank you.
Is that
Great.
better?
Thank you. Perfect.
I appreciate this is a busy slide, but it really gives you an idea of just how many individuals, healthcare professionals, residents in Northwest London will be involved in palliative and end-of-life care. And you can see the different terminologies when we talk about palliative, end-of-life and terminal care, and quite what each one means, but they all under one umbrella are palliative care. And on the right, you can see, so under the palliative end of life terminal, you've got your GPs, but of course your district nurses, occupational therapists and physios, social workers, as Councillor Sheth mentioned, care home staff, very important, and care home agency staff as well. But of course, the most important is the patient's family and friends and those who take care of them. And under the next bit is specialist palliative care. And this is specifically delivered by those with specific training and expertise in palliative care. And again, the two overlap. So you may well end up having contact or support from all or only some of the team on this slide. And what we're really hoping and what we want from us in North West London is we want you to get the right care at the right time with the right people and in line with what matters to you. And that's a big ask, but it's exactly what National and Professor Biwi is going to talk about shortly. And it's what we're going to strive to achieve in North West London. Now I'm going to move to the next slide, just to tell you a little bit more about us in North West London. So in North West London, we are very lucky because we have multiple NHS and charitable hospices who provide specialist community-based palliative care. And this is a list of all the different hospices and NHS services that we have supporting us. So you can see it's a lot, but as we know, we are the biggest footprint in London is North West London. We have the most diverse populations. And so I think that these services absolutely are appropriate. But as you can see, there's lots of them. So coming to the next slide.
Lyndsey, before we move on to the next slide, a couple of people have said, could you please pop it into slideshow mode, which will make it a little bigger for people? Sorry to interrupt.
No, is that
Perfect.
better?
Oh,
Thank you.
There we go. Great. Thank
Thank you.
Great. So the next
Thank
slide
you.
is really focused on what are we doing right now in North West London. So I have my GP, but I also support with clinical leadership in North West London and also locally for me in Brent. And in North West London right now, we're undergoing a review of all the 8 boroughs, of all the community-based specialist palliative care services that were listed on the previous slide. So this was begun back in 18th of November 2021, so almost a year ago now. And I've got some links in this slide deck, and we will share this slide deck for you because this is a great opportunity for you to take a look at exactly what's happening and also how you can get involved and contribute because it's still ongoing. But we are very focused on delivering the 3 strategic priorities. And these are exactly what Professor Biwi, I'm sure, is going to mention as well. But it's improving access, it's improving the quality and improving the sustainability of these services. And the aim is to ensure, as I mentioned, all of North West London residents, their families and carers, and those important to them, have the equal access to the high quality community-based specialist palliative care and support to ensure it's sustainable, it's coordinated, and from diagnosis right through to bereavement, it reflects their individual needs. So we want to support more people to receive the care and die in their place of choice. And place of choice can be their own home, hospice, hospital, it's entirely up to them, but that's our aim, is to try and help us and them achieve that. And the idea is to improve the outcomes for patients and their families when they are accessing the palliative and end-of-life care services. So that's our review. And the next slide gives you an idea of why. So first of all, as I mentioned, it is a national priority. But secondly, we know a lot of people are admitted and dying in hospital in their last years and months of life. And that might not be either appropriate or, as I mentioned in the other slide, that might not be their preferred choice. Particularly for us in North West London, we have about 50% of our population dying in hospital, and that may not be their choice. We know there's a lot of variation. So from borough to borough, and we have 8, we're a big footprint in London, it means that not all residents have equitable access to our services. And we know that we have excellent community-based specialist palliative care and some great partners, but we do know it's a challenge to navigate and access. People don't know what's available to them and how to get the access and the services that they would like. We also are very aware, as Councillor Sheth mentioned, about inequalities. We know we have diverse communities, and we know that at the moment, we are having a difficulty in reaching those communities. We're hearing people want services closer to home. We know that that's important. And a big part of this work actually came from looking at the workforce and sustainability of this particular specialist palliative care in the community, with Pembridge, one of our inpatient units, being suspended at the moment. So that really gives you an idea of quite how fragile this service is, and how we really need to ensure that it's sustainable, but that it meets the needs, as you can see, all of the above case for change, really, of why we are doing this review and why we are engaging as extensively as we are. And finally, it's personalised advanced care planning. And I've got a slide on that shortly. And it's just, we know not enough of our residents are being identified early enough and are being offered an opportunity to discuss personalised care planning. Now, that may not be, not everyone has to engage in this process. And I understand it might not be the right time and the right place. But what we do know is that we should give everyone an opportunity and equal access to have these discussions, and then share what they've discussed with those that matter to them and with the health and social care system. So for us in London, that would be a digital care plan, which we would put on an urgent care plan for London. And my final slide is, these are some links to all of what we're doing in North West London. So if you wanted to see a summary of the engagement so far and where we're at in the programme of work, this is where you would find it all. So hopefully that's all helpful. And then finally, it's the London Urgent Care Plan. So as I alluded to, this is an NHS service for the whole of London, and it enables clinicians across all of London to co-create with their patients digitally shared urgent and advanced care plans. So some of us will remember Coordinate My Care. This is the replacement for Coordinate My Care, and now the way that we record and digitally share urgent important information. It's available to ambulance service, 111, out of hours GPs, and it's something that can follow the patient through their journey of their end of life care, because we know that that journey can sometimes be quite long for some patients and have lots of ups and downs. It can vary for every individual, and that's why personalised care plans are so important, because it's what matters to the individual. So I'm going to stop there. And hand over. I didn't know if Councillor Sheth, you wanted to ask me some questions or hand over to Professor Biwi.
Thank you very much for that, Lyndsey. Grateful to you. And just to reiterate that the slides will be available to those who would like to have them, particularly this last slide that Lyndsey mentioned with various resource links. So we will be very happy to share that after the event. But let me just now take a pause and welcome our dear friend, Professor Biwi, CBE. She is the National Clinical Director for End-of-Life Care for NHS England. In this role, she provides strategic leadership for palliative and end-of-life care across England. She co-chairs the Ambitions Partnership for Palliative and End-of-Life Care, which has 34 partners across health, social care, and voluntary sector. She is a non-executive director of the National Institute for Health and Care Excellence. B is originally from Malaysia and has worked in Ireland, Hong Kong, and has held a number of senior roles within the NHS. And she is currently based in Oxford, where she joins us this evening from, and she is a consultant in palliative medicine. So Biwi, I know how incredibly busy you are, and we are so grateful to you for making the time to join us this evening. And just like Lyndsey, if you could please spend the next few minutes just giving us, Lyndsey was very helpfully telling us about what this particular service looks like in Northwest London. It would be good to understand what the service looks like from the national perspective, and your role and how you are leading that and how you are helping to shape that for us, please.
Thank you very much. Good evening, everybody, and thank you for inviting me to speak, Councillor Sheth, and also to everybody who's giving up an hour of your evening. So thank you for your interest. Yes, I was delighted to come in as Lyndsey was speaking, so I've been able to hear some of what she's speaking, which is brilliant. I am going to share my screen, and hope that I am going to be able to manage that. Right, did that work?
All good.
Perfect, thank you very much.
Right, thank you. Perhaps if you're able to slightly make it bigger so that people can see, is that possible?
I'm
Blow it
not
up a bit?
sure. It's
Okay,
on,
fine. Otherwise, we can see it. We can see
is
it.
it not
That's
on
fine.
the full screen?
We can see it. Thank you.
Okay, lovely. Thank you. So I wanted to start kind of speaking really with a reminder about this quote from Cicely Saunders, which is a fairly famous one. So I guess many of you might have heard it before, but I think it's really important for us to hold that in our head. She said, "You matter because you're you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." And I think every word of that is really so important, isn't it, to what we're all trying to achieve. And Councillor Sheth earlier on told you about the Ambitions Partnership, which I co-chair. And back in 2015 or 2014 rather, we started coming together, all these national organizations across health, social care, voluntary sector, statutory, and also the patient's voice, coming together, sort of saying, you know, what does good end-of-life care look like? What should that look like? And what was really lovely about that piece of work, it took us about a year to work together, but it showed the power of working together outside of the NHS, so right across the board, because I think we managed to get the language right. And I think we managed to get that vision right. So this vision of I can make that last stage of my life as good as possible, because everyone works together confidently, honestly, and consistently to help me and the people who are important to me, including my carers. That was such an important vision that held us all together, that made us think, that challenged us to do that. And we came up with really just 6 ambitions. And the first ambition is each person being seen as an individual. And Lyndsey talked to you earlier on about that urgent care plan and how important that is, because each individual and each person's choice about where they want to be is going to be different. And when we say each person is seen as an individual, we actually do mean also not just the person, but also the people who are important to them and their carers and their families. The second ambition is about each person gets fair access to care. And I'll say a little bit more about that in a minute. Maximizing comfort and well-being, and that's not just physical comfort, that is also emotional comfort, spiritual comfort, recognizing distress and addressing it. Care being coordinated, you know, ordinarily that shouldn't have been a separate ambition, but we all know how difficult it is to get that care absolutely right. And we all, and I'm sure everybody on this call knows of stories, if not personal experiences, of care not working together, not being seamless enough. The fifth ambition is all staff are prepared to care. And we chose that word prepared very carefully, because this is not just about being trained. Obviously, education and training and competence is really important, but so is attitude. And so is support. So staff cannot care properly if they're not supported to do so. So this has implications for everybody. And the last thing, of course, is palliative care, end-of-life care, death and dying, grief and bereavement is part of society, is part of community. So therefore, each community being prepared to help is another really important ambition. So we came up with these 6 ambitions. And I think, Councillor Sheth, you asked me earlier on about what it is that we, you know, what it is that the national kind of picture looks like. We think this is what the national picture should look like. This was launched in 2015 as a 5-year kind of plan. We always knew it was going to be work in progress. We refreshed it last year, and that was when we grew into 34 national organizations who still meet together, who still share the same passion and commitment for improving things. And this is now the 2021 to 2026 plan that guides really pretty much everything we do. So just to sort of give you a little bit more flavor of it, and I think today, probably talking about each person getting fair access to care is probably a good ambition to think about. Each ambition had an I statement. So making, again, really, really clear that this is about the person, and this is about where they live. This is about them getting that good care wherever they are, whatever the circumstances. And underpinning the 6 ambitions are these foundations. So I think they're fairly self-explanatory, and I hope you'll be able to see them on your screen. But as you can see, a lot of what Lyndsey talked about actually picks up on some of these foundations. And some of you may know that in the Health and Care Act that was came into law this year, which created, which gave statutory basis for integrated care boards, EDs, an explicit requirement that the commissioning of palliative and end-of-life care for their local population is a statutory responsibility for integrated care boards. We have published statutory guidance to support that, and we have used these 8 foundations to help commissioners think about, how they're achieving this for their local population. So I hope that gives you a kind of a broad picture of what it is we're trying to do here. And probably the important thing to recognize about the ambitions is what we're saying is, you know what, we don't need planning permission for this. So apologies to people who may be on the call who deal with planning permission, not for the ambitions. You do not need, it's everybody's job, and we've all got a role to play. So I think that's really the message we want to get across. And then we start looking at, okay, so we need to personalize palliative and end-of-life care. And how do we marry that up with what is, what are the personalized care approaches that NHS England is promoting? So on the left-hand side, as you can see, there are some of these approaches like shared decision-making. It's really important, personal health budgets, social prescribing. So all of these things are things that we're trying to promote for everybody. But in the context of somebody who is likely to be in their last year of life, then thinking through, how do we identify people, or how do they self-identify? Because if we don't, then everything that we can offer might not be available to the person because they don't know it's there. On the right-hand side of the screen, you can see the outcomes, which matches the ambitions, and that is about what are the outcomes that we're looking for that help people to live and die well. That triangle in the middle is really depicting a little bit what Lyndsey was showing in her slide earlier on about how people move in and out of complexity and need different levels of support from the palliative and end-of-life care services, both generalist and specialist. And therefore they move up the universal targeted specialist, sometimes moving back into targeted, sometimes moving back into universal care. So this is very dynamic, and we need to work with the person's needs because people want to live well. So it's not like we need to constantly provide the services. It's when it's needed. But of course, that's at individual level. At population level, we're thinking about the whole population. So it's wherever the person is. And I'm sure there will be not everything will be depicted in this picture, but it's just trying to get across the message that it is wherever the person is, whatever their home circumstances, all the different types of services working closely together in order to achieve this. And some of the elements on the outside is what is required if we're going to achieve this. And I think this is particularly important because it's got to remind us about making sure that we look out for people who are underserved, groups who are underserved. And that may be people, we pay attention to protected characteristics, of course, and that's really important. But there are also some people who I think are underserved because of their circumstances, having palliative and end-of-life care needs. So thinking about the person who is isolated, who lives alone, who doesn't have somebody to speak for them. Thinking about people whose carers, whose unpaid carers, their family members are disabled, or very young, or very old, and just trying to manage that kind of, it's harder to measure, it's harder to identify, it's harder to count, but they're the people who do need our support and need to be helped to do that. So what are we doing as a national program in NHS England? And I'm part of this national program where we try to deliver our support through our strategic clinical networks. So London is one of the 7 regional networks, and then the regions work with each of the integrated care boards. And people like Lyndsey have been really powerful, I think, in helping us with various bits of project that will not only helps London, but actually then gets shared across into other parts of the country. On the right-hand side of the screen, you can see 3 kind of big national work streams, and those are the ones that we're working on to try to improve things. That's just to demonstrate the strategic clinical networks and how they're all growing. And over these years, we just have a really strong network of clinicians, non-clinicians, volunteers in the area working together to try and improve care everywhere. So my final slide is about our delivery plan. And again, this is again about what's our focus as a national team and what are we trying to drive improvements in. We're trying to drive improvements in access, in quality, and in sustainability. Those are our strategic priorities. And as you can see, we have identified 3 outcomes for each of those, which really center around identification. Again, back to my piece around unless we can identify people, then we can't offer them the personalized care support planning, which might include advanced care planning that Lyndsey was talking about earlier on. We have in each of the strategic priorities something around workforce, because we need workforce that is confident, competent, fit for purpose, fit for the future, but also that staff, patients, carers feel that they can rely on, that they can get the support and advice that they need. Equity is again a big part of it, equity in terms of the underserved population, but also equity in terms of regardless of what condition or diagnosis you have, we need to have high quality palliative and end of life care. It needs to be sustainably commissioned, it needs to be systems based, and also we need to think about the personalized and community focused approaches, because this is back to ambition 6, where communities are prepared to help. And that is kind of an overview of what we're trying to achieve nationally by, I guess, painting a picture of what good looks like, enrolling, recruiting the support and the commitment of everybody in every part of England. And, you know, I consider myself really lucky to be National Clinical Director in this field, because there is no shortage of commitment and of real desire to improve things on the part of everybody I encounter.
Thank
So
you.
at that point, Councillor Sheth, I'll hand that back over to you.
Thank you very much. And talking about feeling lucky, let me tell you, I particularly feel very lucky to have you joining us this evening, B, and equally feel lucky to have Lyndsey and some of our colleagues with us this evening. So thank you very much to both of you ladies. Really am grateful to you. Now, one thing that really strikes for me from both of you ladies, Lyndsey and B, about you know, you focusing and making this service area all about the person, or about fair access and equity. And I know when we talk about some other service areas, particularly we were talking about mental health a couple of months ago, and we were talking about the stigma around that. And equally, there is stigma around this particular service. And 1 in 4 people are unable to access the care that they need, perhaps. Lyndsey alluded in a presentation about the local service at Pembridge and the difficulties that the local residents has experienced. But let me put this question to Lyndsey first, as the lead GP here in Brent and Northwest London, and as this key person, Lyndsey, I wonder what are the main issues that you find when you're trying to provide care for someone who needs that palliative care, please. And again, I know we had a little bit of a technical hitch before you joined, and we have sadly taken a little bit time of our conversation by sorting the technical hitch. So if we could possibly, you know, have the replies as short and brief as possible, so that I can get as many questions as possible within the time available. Thank you, Lyndsey.
I think for me, it's the same issue as what our residents are facing, which is we're not entirely sure what access and what services we have. I think that we struggle to navigate the good services that we have. And there are some excellent services in North West London. In my slide, I listed all the different hospices and NHS trusts that provide it. But I think my main issue reflects a lot of our residents, which is we're just not sure who does what and how we can gain access to it.
Thank you. So, if I can turn to you, as the national lead, I wonder how you and your team are supporting that conversation to identify various key stakeholders and partners to ensure that the NHS is resourcing it's resourcing its available mechanism in the right direction. I know, we often hear about the challenges that are faced by the NHS, but of course, we know that, and that's not perhaps the answer that we would want to hear. And perhaps, if you could just give us a quick, tangible example of how you and your team are supporting teams like Lyndsey's in Northwest London.
I think we have to be slightly careful, because from a national level, you're seeing things from very far, and really the real information is much more local than that. I think how we support it is by being very clear about what that direction is, what good looks like, and actually saying those conversations do have to happen locally. We also share practice, I think, with, from one area to another, about how different localities may have done it, but how it is in one part of London may be very different to another part of London, and certainly different to a rural part down in the southwest. So I think all we can do from a national perspective is really draw out, these are the key things that are really important to look for. These are the principles. This is who you need to talk to in your area. I do think that as we go forward in the integrated care board system, integrated care systems, I think that is really going to be the key. But those conversations will still have to happen.
Thank you. So we talked about the equity aspect and fair access, and I wonder, Lyndsey, what are the barriers that you are seeing as a GP in some of our residents accessing the care that they need, perhaps?
So thank you. I think,
and then if you go into perhaps help us by saying a little bit about how are you mitigating that, it would be really helpful.
this question's also just come up in the chat from a resident as well, which I think is incredibly important, and I have just addressed it in the chat as well. I think for me, the challenge is, firstly, our colleagues are, our residents are unaware of what's available to them. But that's not just residents, it's the health and social care colleagues as well. And so for me, it's patients and those important to them. They have concerns with engaging early with palliative care. And another resident mentioned about the stigma of palliative care. A hospice is seen as a place where one would go just to die. Is that all they would offer us? But actually, hospices, it's a misconception. They offer so much support to the resident, but also their family and those caring for them, to keep them and stay well. And we actually know that palliative care can not only improve the quality of life, but it actually can extend life as well. So there's that two-pronged benefit to that early engagement. But it's about that psychological part, and that's that stigma-based issue. But then it's also, it's what can we do to try and, as you said, mitigate that. So one of the things that we have organised is we've got a directory of services now that list everything that's available to us, professionals, and so health and social care. And we're also looking at producing something very similar for our residents in North West London, so as to give them an opportunity, empower you to consider what you could and could not access. But it's also, it's moments like this. It's a chance tonight for me to be able to share that palliative is not just for that final moment. Palliative is all the psychological help that goes along with it, the discussions, the beginning of conversations for not just the resident, but their family and their carers who are on that journey with them from start to finish. So I think for me, that's how we're trying to mitigate. But I appreciate it's ongoing.
So obviously communication is the key, it's important. But I think also, as we have said in the earlier part of this conversation, that perhaps early conversation is also the key. And I guess many people feel uncomfortable talking about their wishes for end-of-life care, palliative care. But yet, not talking about them can mean that others make the decisions when the time comes. So I guess I would be keen to understand, how are we supporting people make the most of those conversations about end-of-life care? Because there is still, as we have just agreed, a huge stigma around death and dying, which makes conversations in turn very difficult and prevent the open discussions that would benefit the inherent issues in palliative care, and perhaps, as B was saying, fair access and equality, equity. To either of you ladies, B and Lyndsey.
I think the first thing in terms of conversations and making conversations easier, if you like, is actually we don't have to go straight to the hard decisions immediately. So conversations are opening up. Conversations are about what matters to you. So in a way, that's a way into that conversation. That's one way of opening things up, and also that concept of what we call parallel planning. So just because we're starting to talk about managing symptoms, about the difficult decisions that might have to come later on, about what it's like and how people are feeling, it doesn't mean that they're not necessarily having treatment at the same time. So clinically, I work a lot with people with heart failure. They're having their maximum heart failure treatment at the same time as I'm talking to them about what matters to them, about what kind of priorities they have. At some point, they may want to make decisions about do not attempt pulmonary resuscitation. That doesn't have to be our first conversation. So this is about a process and opening up. And I'd encourage them to talk to their families to start with, or if they wish to, and so on. So I think it's about a gentle kind of approach to just saying talking is good.
Friends, if you have any questions, just raise your hand and I'll come to you within the time that we have. But B, in your presentation, in your slide, you were very helpfully telling us about the benefits about advanced care planning. And I wonder if you could just list one or two areas that perhaps is key to that advanced care planning for our friends.
Yeah, so the key is that it's a voluntary process with somebody while they're well enough to plan for the future. So sometimes it's easier to explain it as it's planning for your future care. So that's important. They decide who they want to involve in that conversation. Some people want to do it on a one-on-one with their clinician. Some people want, people from their family or somebody they trust to be with them to help that conversation. And really that conversation can go from anything from simply expressing what's important to them, what are their wishes, if they were unable to make that decision at the time it's needed. So I will always say to them, whatever you want at the time, if you have got the capacity to make your decision, it will always trump any advanced decision you've made. So those are kind of maybe rather than go through all of it, perhaps just those are probably the key principles.
Thank you. And obviously, we would all like to focus on the person, but also equally important are family,
yes.
And people, loved one around the individual. And I wonder, both you and both B, you and Lyndsey, I wonder what information and support are given to carers and families and the loved ones, so that during this pretty emotive time. We are supporting them in a meaningful, tangible way as best as we possibly can.
Lyndsey, do you want to go first or shall I?
You can begin.
Okay.
You might echo each other's.
I think so. I think so. So I think the first thing is to acknowledge that I'll call it the family, but it may not be family, maybe somebody who's really close to the person, is first of all to acknowledge that they're going through something really tough as well, that they are often also part of the team, the caring team. So that there's a lot of things going on for them at the same time. They're also having anticipation of loss and the grief and bereavement. So there's a whole stack of things. I guess in terms of support, there's various things. There's the emotional support, there's the information support, there's the practical support, and if they were at home, knowing who to contact and how to contact if they need help and advice. So I think that's probably the basic, yeah.
And B, if I can interrupt, forgive me.
That's okay.
And what about the cultural support? Because obviously we have right across Brent and Northwest London, hugely diverse populations. And I wonder how we equipped all of our frontline staff, our workforce, who do amazing work, absolutely amazing work. How do we equip our colleagues to be culturally sensitive to those needs, please?
I think to start with, actually asking the question rather than assuming we know, because even within any one cultural group, there will be differences and diverse views and opinions. So I think it's not making assumptions on behalf of other people. I would hope and expect that at a local level, people who are working in that area will also have the support and the interaction with local community leaders, local group leaders, so people who share the same culture, who can also help to support and interpret wishes as they come up as well. That would be my view.
Thank you.
Lyndsey, of course, is
did you want
practicing.
to add from the local perspective? It'd be good to, I know you're based in a very busy GP practice in a hugely diverse neighborhood. So it'd be good to understand how you and your team go about supporting our residents.
So for us in Brent, I'm going to give a shout out to Brent Health Matters, which is a new programme of work, reasonably new programme of work, where we are really focused on health inequalities. And only last week did they invite me to join their meeting, and I'm producing a resource that is public facing, where the patients and those caring for them, informal carers, but I always think, or unsung heroes, or the ones that are, as B said, are along the journey, but sometimes unrecognized along that journey. And so I've worked with, so I'm engaging with our voluntary sector, multi-faith organisation groups are giving me feedback. So we're really trying to pull this together to make this resource something useful. It's never going to be perfect. I know we're not going to get everything in there, but it's a start, because I think, as I've mentioned in the chat, we've got some great communities. And I think Imran, someone was saying in the chat, how they've supported their local community. And I think there's so much good going on. And I think it happens in pockets. And what I'd like to do is try and bring it all together so that you know what's happening and how you can engage. So that's what we're doing in Brent. And actually, as part of that, I'm going to bring that with me into my Northwest London role.
Thank you. And I think Brent Health Matters do amazing work. Thank you very much for putting a spotlight on them, Lyndsey. And Lyndsey, by the way, thank you very much for all the replies that you're giving to various different questions that I put in the chat. Thank you very much. Wonderful. Now I can see Sandra's hand being raised. So let me bring Sandra's question. And if there are any other quick questions, do raise your hand and I'll try and bring you in. Sandra, good evening to you. Good to see you.
Yeah, good evening. I'm Councillor Sandra Kabir, a councillor with Brent, and have quite a bit of involvement in health issues. I have one particular question. First, I must state that I'm really pleased that at last the NHS is opening up to voluntary organizations and communities, faith organizations and other things. This should have happened years ago. And I hope you take this in a positive way. Now, when we want to involve the voluntary sector, voluntary organizations or charities, as some people know them as, or even informal groups, they need support to provide support to people who need help. So that support could be in terms of training, and access is a big thing, because quite often from the voluntary sector, and I have a voluntary sector background, one of the issues that comes up repeatedly is GDPR, that information cannot be shared because of GDPR, and that creates a brick wall that you bang your head against, and then you can't make any progress. So I think as we go along in this process of involving all partners in this process of the improving the end of life quality of care, is that how do we support informal and formal voluntary and community organizations, and how do we break down the barriers? And GDPR is just one of the barriers.
Thank you very much for that. A quick response would be appreciated, B and Lyndsey.
Okay, I think the GDPR is a tricky issue, which I'm not going to attempt to sort out in this, but you're quite right. I think we start breaking down the barriers by valuing these organizations and recognizing and having those conversations, because that's really what will break down those barriers.
Thank you very much for that. Margaret, good to see you. A quick question from you.
Oh, hang on. Oh, hi there, Kid. I was literally in the midst of typing, saying that I did put my query in the chat box. I was just, because I know that there are issues surrounding those patients who are palliative who want to pass at home. But when the time comes, it's the families where the issues lie, because at the last moment, issues might arise. So that person's wishes aren't taken into account, and they end up in hospital. I know it's quite a high amount. So is there something we can do where, when it comes to the very end, that families, no, we're taking through the journey, but, you know, at home, and I'm not saying it's not a stigma or anything, but having a relative die at home in certain cultures means different things. So is that being taken into consideration by the professionals who support, so that person can get the choice of passing at home?
Thank you.
I think I think that's a very good point, Margaret. And I think for us, so here's the thing: it's patient choice, and then it's a change in patient choice. And that's where we have to consider how rapidly we can get things in place in order to support that change in choice. And having had a personal experience of something unfortunately very similar, where we were attempting to get out and get mum home, it was just impossible with the right equipment, with making sure that the team at home could set her up with the right syringe driver, and we just didn't get it done in time. And I'm end of life lead, and I still didn't get to achieve quite what we wanted to achieve with my mum and what she wanted. So it's what we can do with that rapid change. And I think it's something that we're committed to in Northwest London, is that it's what can be safely done rapidly. And that's where it's just a bit of a chicken and egg, isn't it? And we're working on it. If I can give you we are very aware that this is a need, as are all our communities-based services. But we know that we need to respond rapidly.
Thank you very much, Lyndsey. Thank you.
Thank you very much for that. We are almost coming towards the end of our time, but I want to very quickly squeeze in one or two questions. I wonder, Lyndsey and B, both of you, if there was one thing, I know we got these 6 ambitions, B, but and I know, Lyndsey, from the work that you and I are doing in Northwest London, all the wonderful stuff you're doing, but I would like you to share, both of you, if there was one thing that perhaps you could change pretty quickly to make that tangible difference for our residents, what would that be, please? First Lyndsey and then B.
Oh gosh, there's so many on my wish list. But I think for me, it's engaging
I guess
earlier.
the
It's
obvious one is
engaging
the
early. It's engaging early and having the time to have these conversations over time. I think
Great.
there's never enough time for me as a GP. More time and
Great.
earlier conversations.
Great. And while you were speaking, I overspoke, and I was just going to say, apart from, it's good that you said something different, because I was going to say, apart from equity and fair access, I wanted something else. So thank you for that. B?
I think the recognition that everybody has a role and a responsibility and a contribution to make. And I really do mean everybody recognizing that in themselves and in other people.
So with that in mind, that very nicely leads me to perhaps the final point to Lyndsey. Lyndsey, in your presentation, and I think in one of your replies, you were saying how important it is for everybody to get involved. And I think in your penultimate slide, you had various links. It'd be really helpful for our friends on the screen right now, and those who are joining from other platforms and will be looking at this at other times because this is being recorded. It'd be really good to know, how do our residents, whether they're based here in Brent or elsewhere, get involved, and physically get involved, I mean, to make that difference?
Yeah, so we have a website that is regularly reviewed and updated. I have posted it in the chat, but if you just searched into Google the Northwest London, so NWL ICS, and put in palliative care or community-based palliative care, you would see it. And there's a big bit right in the middle that says find out how you can get involved on our first page. So I'm going to copy and paste, and my final paste into the chat is the link to our Northwest London website. So it's www.NWL. So it's Northwest then London ICS.nhs.uk/get involved. And that's exactly how you can get involved.
Thank you very much. Judith, we come to you for the final few words, but Lyndsey, B, and all the friends on the screen, thank you very much. And I say this every single month, 1 month, 1 month, hopefully I'll be able to say that we've had enough time. The clock always beats us, but this was just the start of conversation. And I'm going to get Lyndsey and B to come back very soon so we can have part 2, and perhaps we'll have perhaps much bigger slot to have as many questions answered as we possibly can. But let me just pass you over to Judith for a few closing words.
Yes, thank you. Live well and die well. I found this evening's session very moving and also very encouraging. Your commitment shines through. So thank you to Dr. Lyndsey Williams and Professor Biwi. Yeah, as I say, your commitment to people living well and dying well absolutely shines through. So it's always it's an ongoing conversation, as Ketan has just said. And certainly on behalf of the Advocacy Project and Health Watch in Brent and Westminster and Kensington and Chelsea, we're really keen to continue the conversation. So let's look at what we can do as a second and subsequent session to really develop that and see how we can all join things up even more. And thanks always to Councillor Sheth for his incredible chairing and pulling things together. Well, great job as ever. We've run out of time, so I won't tell you what our next session is going to be, next month's session. We will be sending by email to everyone that's on the call and also those connecting via other platforms, the link to the recording from today, the slides, the resource lists, and also we'll put in what next month's subject it is. So thank you and take care, everyone.
Thank you.
Thank you very
Wonderful.
much. Thanks,
Thank you
Ketan.
very
Thanks,
much.
Judith.